So, good evening, everyone, and namaskar to all the people on board. Myself, Vimmi Choudhry, the facilitator of this meet. On behalf of IHW Council, I welcome you all to today's talk show. Ladies and gentlemen, as you're aware, IHW Council is a council that has been working towards creating awareness and advocacy for a healthier and a happier world. And towards that, we have been organizing these talk shows and other sessions. In fact, today's talk show is a part of a month-long campaign, the Breast Cancer Action Month, which is being presented by IHW Council and Novartis India. And further, as you're aware, around the world, the month of October is observed as the Breast Cancer Awareness Month. And so this whole month of October, starting from the 1st of October to the 31st, we have dedicated our efforts, we have dedicated this campaign to all the brave men and women who are combating this disease, who are fighting this dreaded disease. This, ladies and gentlemen, is the second edition of the Breast Cancer Awareness Campaign, wherein we are bringing together all the stakeholders, from the policy makers to the experts, to the oncologists, the social workers, the influencers, and also the cancer warriors who have successfully fought and overcome breast cancer. And our endeavor has been not only to sensitize people, to create awareness among people, but also motivate everyone, to inform everyone, to be more aware, to be more conscious, to be proactive, so that they don't lose hope and believe that yes, they can win over breast cancer. And we believe that with our endeavor, if we are able to save even one life, this campaign will be a success. So before we deep dive into the discussions which we have with our esteemed panelists, let me at the onset give you a recap of all the ground that we have covered in our campaign so far. And towards that, we bring you a short video. We bring you the glimpses of 2020 and 2021 shows done so far.
As breast cancer is the #1 type of cancer in women today.
मुझे आज ब्रेस्ट कैंसर एक्शन डे से उम्मीद है कि जागरूकता और उपायों के बारे में लोगों को बताकर हम देश में ज्यादा लोगों के बीच कैंसर होने से रोक सकते हैं.
I'm confident that the contribution of the Integrated Health and Wellbeing Council will certainly help in checking and treating cancer.
That this is preventable, provided we feel ourselves on a daily basis. We love our bodies, we value them and take care of them.
The problem is really at two levels. One is with the media centering a lot of communication around what is significant in that month. And the second is, as a society itself, we just don't want to mention the word breast.
We have to create a complete ecosystem so which can really help early detection, early treatment, and help patients live a longer and healthier life.
The most important thing is to be aware of the risk of, that you're a female, you can get breast cancer.
We need a multidisciplinary approach to tackle this menace. We need to have a multi-pronged strategy comprising awareness programs, need to take preventive action.
If we can do the awareness, do the best early detection, if we can downstage the disease from stage 4 to stage 3, even about 20% of patients supposed to be downstage them, then I think for last coming 5 years, our job is done.
amongst all, as per the ICMR, recognize that the most deadly one is the breast cancer.
We must channelize them towards adopting a healthy lifestyle that will reduce the risk of cancer.
If our female students become aware from the very beginning of the life, then the chances of breast cancer will be reduced considerably.
Decentralized and integrated breast cancer care supported by data and digital.
It is early is to be treated early. That's the bottom line for me.
You should live each day as it comes, and then you aspire to inspire before you expire.
I see a lot of hope in CSR. Corporates can have a cancer fund for their employees. Why not?
Basically bring the funding agencies together and to channelize, harmonize and prioritize cancer research in India.
Make the education better for consumers, but also the education has to evolve for the medical professionals, the nurses, the health staff and all of that. Put the budget together. How do you find someone to be able to fund all of this?
There must be teamwork or integrated approach of breast cancer management.
It's really about driving education, sharing the latest information, and building a platform to allow exchange of different ideas.
So, ladies and gentlemen, these were the glimpses of the year 2020 and 21, the road which we have covered till now. And as we heard, breast cancer can be prevented, it can be treated. And the very first step towards it is towards creating awareness among the people and making women breast aware and speak about it and reduce the risk. Unfortunately, we know that breast cancer has become more prevalent than it was before. In fact, just to share with you, as per the Union of International Cancer Control, the female breast cancer has become the most commonly diagnosed cancer across the world. Even in India, the cases have been rising among women of all ages. And one thing is certain about cancer is that the amount of havoc it can actually play in our lives, in the finances, in the lifestyles of those who go through it, which definitely makes it more imperative for everyone to start thinking of taking a health cover as soon as possible. But then the cost of assessing healthcare services is one of the biggest challenges in India. While there are some options such as health insurance, there are a lot of barriers to it. Many people do not, in fact, understand the very concept of insurance, while many fail to understand the need for insurance. And this pushes up the out-of-pocket expenditure for patients, and it also significantly affects a patient's family. Just to share with you, ladies and gentlemen, as of 2017, only 44% Indians had health insurance. As of 2020, the health insurance schemes cover about 500 million people, thanks to the Ayushman Bharat, which was launched by our Honorable Prime Minister. So today, we will discuss how insurance can help in breast cancer treatment with our elite panelists. And our focus is on healthcare funding sources for breast cancer care, the insurance inclusion of oral treatment under healthcare insurance, increase of sublimits wherever included. And joining me today in this conversation are very renowned experts and professionals from the sector. In fact, we have two doctors on the floor, one insurer and one pharma company. Let me quickly introduce our esteemed panelists. Very thankful to Dr. N. Aditya Murali joining us, the senior.
Hi, good evening.
Good evening. Good to have you with us. Dr. Murali, ladies and gentlemen, is the senior consultant, medical and hemato-oncology and bone marrow transplant physician at Aster Hospitals, Bengaluru. Dr. Murali has a very vast experience in the treatment of lung cancer, breast cancer, ovarian cancer, lymphomas, leukemias, with almost 5,000 cases to his credit. Dr. Murali specializes in the field of immunotherapy in lung cancer, targeted therapies in the management of blood cancers, and he was also a part of the team which performed the first haploidentical bone marrow transplant in Faridabad. Our next esteemed panelist is Dr. Mounika Boppana. the consultant medical oncologist at Krishna Institute of Medical Sciences, Secunderabad. Once again, someone who has a large body of work and experience in the field. Thank you, Dr. Boppana, for joining us today. And we have Mr. Jose Peter with us, the co-founder and the CEO of Arogya Finance. Arogya Finance is a social healthcare venture, a thought leader and a pioneer in the concept of medical loans in India. And since its very inception in 2011, Arogya Finance has been at the forefront of providing innovative medical loans to patients. The company has carved a niche for itself with innovation, pricing, prompt services, and reliability. And our next esteemed panelist, Mr. Niccolo Nitti, who joins us from Mumbai, the head people and organization Novartis. Novartis, as we all know, is one of the largest pharmaceutical companies in the world, based in Basel, Switzerland. They are reimagining medicine, and their people and organization, they are building an inspired, curious, unbossed culture to be innovative and discover new ways to improve and extend people's lives. So thank you to all our panelists for joining us. And we
Thank you and good evening to everybody.
Good evening again.
Thank you, Vimmi, for that introduction. Thank you.
Thank you. And if I can just request all of you to have your mics on, because we are now going to be moving into a discussion. And so as we are talking about oral treatment, as we have a focus towards it, my first question is going to be to Dr. Mounika Boppana. Can oral treatment help cure breast cancer? And can everyone be also treated with oral medicine for breast cancer? If not, then how do you judge or who are the right candidate for oral treatment?
So, hi. Every breast cancer patient is not amenable for oral therapy. Am I audible?
Yes, ma'am.
Yeah. So we decide whether a particular patient is suitable for oral therapy or not based on something called as receptor studies, which we do on the tumor tissue, either the biopsy or if the breast has been removed and there's a tumor in it, then on that tumor, we do something called as ER, PR, and HER2 testing. So we test the tumor for hormone receptors and another receptor called HER2. If the patient is hormone receptor positive, that's ER and PR or ER or PR positive, then the patient will be amenable for some form of oral therapy. If the patient has, early stage breast cancer, which is in a curable stage, it has not spread to other parts of the body, then we do whatever initial treatment, surgery, chemotherapy, radiation as required based on a case-to-case basis. And then after that, we put them on hormone therapy tablets in order to further reduce the risk of recurrence. If the patient has stage 4 disease from the beginning itself, then we decide based on what is the disease burden, how symptomatic the patient is. Based on that, whether chemotherapy is required or whether it can be managed with hormone tablets or other forms of therapy alone. So this is how we decide whether oral therapy is suitable or not. In chemotherapy drugs also, we have a few oral tablets like capecitabine is one such drug. So we do use that also in certain patients, in certain scenarios. It's one of the important drugs which is used in breast cancer. And similarly, the other receptor that I talked about, HER2. So if at all a patient is HER2 positive, most of the HER2 targeted therapies are injectable drugs. But there is an oral drug also which is directed against HER2 that's called as lapatinib. So we have a handful of drugs which we choose, oral drugs which we choose based on how the receptors are, whether ER, PR, HER2 are positive or not.
And this treatment stands effective?
It depends on, again, what scenario we are dealing with. If we are dealing with a curative setting where it's in a curable stage, then basically the tablets are usually initiated at a point of time when there's no longer any obviously visible disease in the patient's body. She has completed all her treatment, and any microscopic disease which might have been left behind or in order to prevent the action of hormones, we give these tablets in order to reduce the risk of recurrence. Now, there are patients who do recur even while taking hormone therapy. And there are patients who do well on hormone therapy, which is given for about 7 to 10 years, depending on what hormone therapy tablets we're choosing and whether the patient is premenopausal or postmenopausal. So based on that, we choose. Again, in the metastatic setting, that is when the disease has already spread to other parts of the body, any tablet form of therapy that we give will control the disease for a limited amount of time. It's not like indefinitely the tablet is going to act. It's not like tablets taken for high blood pressure or diabetes where lifelong a patient can remain on a single tablet. It's not that simple. See, cancer is a very complex disease and the cancer cell is quite intelligent. What it does is after being exposed to a particular drug for a certain amount of time, it starts developing resistance to that drug. And it starts evolving different mechanisms by which it can escape the action of that drug. So that's how it becomes resistant and a very stubborn kind of a cell, and that drug no longer works. Now, how long the first drug that we give to the patient works is again highly variable and it's very complex. It depends on the disease biology and the individual patient. Sometimes the initial hormone tablet that we are starting for a hormone positive metastatic breast cancer patient, it might work for 1 year or 1.5 years. Lucky patients go up to 2-3 years old, so they do well. But eventually, they do develop disease progression on that tablet. Then the time comes to change that tablet to something else. So that's how it works. It's not like any therapy. It doesn't work indefinitely. It works for a certain period of time, after which it stops working.
So the patient has to keep consulting, and maybe you will have to change the treatment depending upon how he's
Yes, that's the reason why we call them once in every 3 months or 4 months, sometimes once in 6 months also if the patients are doing really well. But intermittently, we do have to do scans like a PET scan or clinical examination, and the other thing sometimes a CT scan. So we need to check how the disease is progressing, whether it's still under control, whether it's increasing on whatever treatment we are giving. Because if it's increasing, then it's time to change the therapy. So periodic follow-ups are necessary, basically.
Thank you. Thank you so much, Dr. Boppana. And in fact, I would like to also ask Dr. Murali, what has been your experience with oral medicines for breast cancer? Have you treated anyone? And if you can share with us the experience and the results.
Thanks for asking this question. So oral medications are a very effective form of therapy, and unlike public perception that only IV is effective and oral is not, advances in science have ensured that we are able to target the actual disease pathway involved, and we are able to give very effective, at the same time lot less toxic oral medication. So oral therapies have been used, as said by my colleague, at every stage of breast cancer. They have been used in the early stages of breast cancer to reduce the risk of recurrence. Also, they've been used in an advanced cancer setting to keep the disease under control for as long as possible. The really attractive part of oral therapies, especially in COVID times, is that it reduces the hospital visit to a significant extent. Less exposure to a hospital, less chances of picking up the infection. So that was one very significant attraction towards oral medication. Another significant attraction also is the fact that the less hospitalization is there, the less is the cost of treatment. And all of this put together do ensure that patients are able to stay on effective medications for a longer period of time.
Thank you. And in fact, you mentioned about COVID. So does the COVID treatment, if a patient also has COVID, does the COVID treatment affects or impacts the cancer treatment and vice versa?
So when we are talking about conventional chemotherapeutic medications, yes, COVID does impact cancer treatment. In fact, if patients do have active COVID infection, we try to postpone active IV chemotherapy, especially, when the first pandemic was not, the first wave was not too bad, but the second wave was absolutely deadly. So during second wave, there were a lot of instances wherein we were able to sort of postpone the IV chemotherapy treatments and try and put patients on oral medications. that way ensuring that the disease stays under control, because oral medications do not hit your immune system that much, and they do not interfere with COVID treatment. And in fact, they can be continued. Some of them could be continued even when patient has a COVID infection.
In fact, I would like to once again go back to Dr. Boppana. And is how's this treatment cost effective? Is it possible for someone who doesn't have an insurance to avail? I mean, is it possible for anyone who does not have an insurance to avail these medicines?
Some of the drugs are quite cost effective. In fact, compared to IV chemotherapy, some hormone therapy medication, they're quite cost effective. They're cheap because we have generics available for most of them now. So they're no longer costly. But there are some drugs like the specific targeted therapies, like, for example, CDK4/6 inhibitors like palbociclib, ribociclib, abemaciclib. These are the drugs which are quite expensive, and for someone who doesn't have an insurance or any other credit, like we have CGHS patients, ECHS patients taking treatment under company credit. So if they don't have any such support, and if they have to spend from their own pocket, it becomes quite expensive for them, because it's not that they just have to take it for a month or two. It's like almost like a prolonged therapy that might extend into years, 2 years, 3 years. So that becomes quite expensive in the long run. Overall cumulative cost is quite high. Although most of these companies have come up with patient assistance program, which is quite good. It's variable. I mean, there are minor variations from company to company, but by and large, the principle is that if the patient buys a drug for say 9 months or 12 months, then the remaining, like for however long the patient would require that drug additionally, in addition to 9 months or 12 months, that is being given free of cost by the company. So that way, and in some companies, we also have those who are below poverty line, BPL patients, or who have the white ration card. They are collecting the details, and they are checking for the authenticity, and they are providing the drug completely free of cost also. So in the absence of all these kind of support systems, these newer targeted therapies, which are being increasingly used over the past half a decade or so, 5-6 years or so, they are quite expensive. The older hormone therapy drugs, the conventional hormone therapy drugs, they are cheap, and they are quite amenable for anybody to buy from their pocket. Although daily wage laborers, for them to spend 2,000 to 3,000 rupees a month continuously for years together might be difficult even for them who are in the BPL range. But apart from that, like most of the patients are able to manage the older drugs, which are still quite effective. But the newer targeted therapies, patients are finding it difficult to buy, certainly without any support.
If you can give a fair idea on how much is the per month cost it comes to?
It comes to somewhere around 70 to 80,000 a month if they have to buy these drugs, the CDK4/6 inhibitors, with maybe about 10,000 plus minus variation between company to company. So I can say that the cost would range somewhere between 80,000 to 1 lakh a month. And like this, if they buy for 9 to 12 months, then it's lifetime free. Lifetime as in patient would probably be having good disease control maybe for another 6 or 12 months at the most. More than that, we see very few patients going. So an average patient maintains good disease control on these drugs for about 1.5 to 2 years. So 1 year around the company is giving free of cost, and maybe another 6 months to 12 months, 1 year the patient is buying, and another 6 to 12 months the company is giving free of cost.
Yeah, thank you. But as I see, it is pretty expensive. And
pretty expensive.
Pretty expensive, yeah. So that is where I would like to bring Mr. Jose Peter. Is breast cancer covered in regular insurance? And if you can give your views as an insurer, is oral treatment for cancer also more, as you might be getting many other cases also. So is oral treatment for cancer more costly than other forms of treatment? And is oral treatment covered in insurance?
Yeah, so good evening. So the problem really is not whether it is covered under insurance or not. The issue is how many are able to take advantage of the insurance. Even when you say that about 40 odd % is insured, the significant number of them are underinsured. The last data says that about about 94% of people who are insured are underinsured to the extent of 60%. And when it comes to oncology and cancer, this issue is even bigger because, due to surgery and various other costs, diagnostics, all of that is expensive. And by the time they really reach to the treatment, they would have often ran out of insurance. So it's a major challenge. Even financing. So as you know, Arogya Finance, we are focused on financing such patients, those who are not covered under insurance or are underinsured and wants additional support. We look to give them financial options. Even financing them used to be a challenge because the disease conditions are such that people are wary of financing such situations. We have luckily, and good for the patients and those who are providing these therapies, we are today able to support most such patients. So today, we don't look at the clinical condition of the patient. We look at their financial condition, their long-term financial condition. Even if the patient is in a advanced stage of cancer, even a terminal case, we do not differentiate. We finance those cases so long as they have the ability to repay over a period of time. So yes, we are able to create those options, and anywhere from a lakh of rupees to even a 20 lakh rupee treatment, we have been able to finance, in conjunction with those, caregivers. So yes, yeah, we are getting there. Significant number of patients are able to benefit out of these, payment options. So in the case where Dr. Boppana mentioned about, paying for about 6 months and then you are available for about 12 months free, or maybe 1 year you pay and another 1 year free. So if you are able to create those payment options for that first 6 months or 12 months, then the patient is home. Yeah. So that's the kind of treatment options that we are able to create. Working with multiple, pharmaceutical companies to provide, solutions which solve specific problem of those profile of customers and those therapies. Yeah. Yes. So we are able to do that. Yeah.
And how does a patient or his family approach you?
They approach mainly through the hospitals and the pharmaceutical companies. All that we need is a phone call or a mobile number, and we will reach out to them. We are also looking to create a QR code option where you just scan and then we can, it will open up our application form, and then in a matter of minutes they could apply, and a significant number of them will get an instant approval for the loan. So we are trying to see how we can take the financial part of the problem out of the equation, so that the families and the patients can focus on the clinical part of it.
Thank you.
And the advantage obviously is that, okay, in an insurance, the damage is already done. Either you are insured or you are not insured. And once you have cancer, nobody is going to insure you, right? So if you are insured, fine, you're lucky. If you are underinsured, then again a problem. But in our case, at least, we don't have any such issues, whether you are insured or not. So long as you have some ability to pay over a period of time, we are able to help. Our approval rates are close to about 80%. So, so significant number of people are able to get into that, into that financing option. We are able to do that because we use some unique methodologies like a psychometric approach to credit evaluation rather than looking at documents which are not often there. Yeah, so that's how we are able to solve that issue.
Thank you. I'll come back to you on that later. But herein, I would like to invite Mr. Niccolo, Nitti. As we know, and as I mentioned also, that medical insurance is not considered a priority by many. So do you think taking this insurance should be a responsibility of the individual, or should companies and employers also take efforts in providing it?
So, and again, good evening. I do think that it should be a concerted effort by the individuals, by the companies, and also by the government. So, of course, it's important that also the government should be on awareness and importance of having a health insurance among the public. And but also I think that company as an employer have an important role to play. So for example, what we are doing in Novartis in order to make awareness is through 3 different channels. So we are trying to make awareness about the different diseases, and this is for example one example also of disease awareness. We are trying also to make our associates aware about the importance of prevention, and for example to have checkups, regular checkups, in order to detect if there is something wrong as soon as possible. And we are also making quite many awareness campaign about our health insurance offerings, because we have different insurances, and through testimonials, through real stories, we are trying to really making people aware that to have an health insurance is important, and can prevent quite a lot of economical troubles also. Yeah.
And I think, it can be really prevented at the very first step if screening is done. So you hold certain campaigns in your company, some programs like this where you have screening?
Yes. Yeah. We do it, and again, also we are promoting a checkup, so a yearly checkup, so people can have different, exams in order to, check different diseases. And that also as Novartis, we are working on different therapeutic areas. So our efforts are not focused just on breast cancer or more general in cancer, but also on other therapeutic areas like heart failure, like migraine, like other important diseases. So yeah, again, to reply to your question, I think that it's very important that also the companies are playing their role in terms of making associates aware of the importance of prevention, the importance of having an health insurance, and so on and so forth. Yeah.
Thank you for sharing. Mr. Peter, I would like to invite you once again. Now, you've might be getting many cases, as you said, that people approach you for loans. From the, as you provide loans, if you can share with us certain issues and challenges which are there from the patient's point of view, which you have seen, and even when you're approaching the, connecting them with the doctors and the hospitals, anything from that point of view, and from the insurer's point of view?
Yeah. The biggest difficulty that I found is that the doctors, the oncologists and doctors, they are very busy because of the high burden of disease and issues, and everyone wants to go to the most sought after doctor all the time. So doctors are very busy. Therefore, they don't get enough time even to do clinical issues. How do you expect them to solve their financial issues? So that is a challenge. One way this is being addressed is by the support staff in the hospitals, where the support staff step in and counsel their patients, help them with the financial options, etc. As I mentioned, all that we need is a lead. Somebody connecting us to a patient with a mobile number is good enough for us to pick it up from there. But we know that there are many cases which falls off because people are reluctant to think about financing options when it comes to a disease, because historically patients and families paid for expenses like medical out of pocket. They don't like to borrow for that, which is the right thing. I mean, if there is a way you can pay for it yourself, if you don't have insurance, you pay for it yourself. And as you know, the burden of out-of-pocket expenditure is as high as 60% in the country. So it's a lot of burden falling into low-income families largely. And their general reluctance to go for a financing option. All of these are impediments, but we are trying to solve them by counseling them, helping them with that process, making that process very quick. There was a time when these processes used to take about 3 days and maybe half a dozen documentation. But today we have reached a stage where we are able to do that in a few minutes, often with just KYC. The only document that we seek from that patient or family is the KYC document, which is a statutory requirement. But other than that, we don't bother them with documentation. We try and get some of those documentation online from sources that are legally permitted. And then we take a decision very quickly, and as I mentioned, significant number of them get automated approvals. Counseling is very important. Now the problem is that most finance professionals and companies are tuned to counsel financial. Their counseling methodologies are very different from what is required for healthcare. So in our case, so in a normal finance company, these people are called credit officers or credit managers. The moment you hear credit, people get worried. Yeah. So and the kind of questions that they will ask also will be similar. So we are very conscious of that. So our people in the field, they are called finance counselors. They counsel the patients. They counsel the patient, their families. They put them to the rest, put them to comfort, and then guide them through that process. So today I would say that we have significant success there. We do not have many issues where families and patients complain saying that these people are scaring us by asking all the kind of clinical questions and various things like that. Today we have a methodology which is pretty neat, simple, and very comfortable for a patient. So the area where we need more help, and I'm sure the families and patients will require, is there are doctors and hospitals who make that process much simpler, much easier. A word from the doctor makes a big difference.
So that is where I would like to, in fact, bring Dr. Boppana.
That's right. Yeah.
Anything, ma'am, on again financing, and as you mentioned, certain issues where they seek the help from the doctors.
Yeah, so here the thing is, what is missing is things like Arogya Finance, they have started doing a very good job. And the place where I was trained for medical oncology, that is Tata Memorial Hospital in Mumbai. And there we had a very good social support system within the hospital. There was a medical social worker department, and it had a head of the department, and it had a very well-knit network. And they used to collect funds from different sources, right from major companies as a part of their corporate social responsibility. And there are many non-governmental organizations, there are many NGOs that support. So they are funded by different people, even NRIs as well as other foreign nationals. Many people send their funds for cancer patients, especially if one of their family members has recovered from cancer. They make it a point to give funds to such NGOs, which can be pooled up and which can help a particular patient. So what the medical social worker department used to do is it used to collect information regarding all these various funding sources. They had all the information ready with them. So as we see a patient and we know that, okay, the cost of therapy for this patient is going to be quite high, even in a place like Tata, where most of the drugs, good quality drugs, are given at a much subsidized price. But of course, drugs like targeted therapies, which are the latest additions to the therapeutic armamentarium, they are quite costly. So even in Tata, they are quite costly. So for such patients, we always send them to the medical social workers, and they assess the financial background of the patient, and then they see from which funding source the patient can be best served. So all what we used to do is we used to write on the patient's file that to please go to the MSW for financial support. And then they assess the patient, whether a curative patient or a palliative patient, what is the chance that this patient would get cured? What is the life expectancy? Is this patient a breadwinner of the family? And these kind of other aspects also, because, you know, when the funds are limited and they need to cater to so many people, obviously, it's like, you know, the Darwinian principle of survival of the fittest works everywhere. So most of them like to spend money on a patient who has a more chance of living for a longer time, rather than on a patient whose general condition is very bad and the chance that he or she would make it through the next few months is also quite bleak. So like that, we had a very well developed social worker system in place within the hospital. So we need to have something like that even for the private sector, where they would guide. It's not just one finance company or one health finance company or one insurance company serving patients. It should be like different funding sources, like even the major companies, like say, for example, Reliance or Bajaj, they have CSR, right? They need to have a corporate social responsibility. So why not donate towards the treatment of cancer patients, allocate funds towards them? So a particular institute, especially those hospitals which are treating only cancer patients, like the place that I am working in right now, KIMS, it's a multi-speciality hospital where all diseases are treated, but there are quite a few hospitals in every city which are exclusively oncology hospitals. So every corporate hospital should have a department in place where that department, whatever it might be, having 4 or 5 people or 10 people, whatever, depending on the hospital's staff, whoever are available, they need to be trained on how to track these funding sources, how to, whom to ask, where to go, and they need to pool up funds and like a trust account or something under the name of the hospital, and that it has been, it has received, say, 10 lakhs donation from so-and-so company for the treatment of cancer patients. And like that, the funds which are available need to be expanded. And every patient who's poor needs to be assessed. What is the therapy? What is the cost? What is their affordability? If not the whole entire treatment, say a drug costs 30,000 a month, at least 50% of that can be funded from that organization. You know, things like that can be worked out. So it's like it should be like that. These kind of social worker department should be there in addition to the other departments.
True. Even I feel, you know, that connecting the patient to the people who are going to be funding and the doctor connect has to be established. Probably each of them are working in silos. And at the end, it's the patient who's suffering. So.
Yes. And that will happen. See, it's very difficult for us to communicate with a lot of people on the outside. There needs to be somebody in the hospital. Like, as I said, in Tata, when we send a patient to the MSW used to call us, and then they used to ask us, Madam, what is the life expectancy of this patient? Is there a chance of cure? So this is the status. So how much do you think will be required for his treatment? So this kind of a direct communication used to happen with the person who refers that patient to the MSW. something similar, because it's very difficult for us also to communicate with n number of people outside the hospital whom we don't know or whom we don't have a rapport with. It's easier for us to communicate with a department in the hospital. So this is something that needs to be, which probably I don't think any hospital, or at least I've never heard of any corporate hospital having a social worker department, because it really goes against the whatever practices of a corporate hospital. I mean, they do treat patients under government schemes like Arogya or Arogya Bhadrata and the other schemes, and in the center it's Ayushman Bharat, but there are so many drugs which don't fall under their whatever drugs which come and which are covered under these schemes. So for such patients, we definitely need some other funding sources. We can't keep relying only on the government. It's very difficult because the resources are limited. So there needs to be something else also, like NGOs and these other things. For kids, there are a lot of, for kids cancers like Can Kids and like that, there are so many organizations which fund treatment of kids, but very unfortunate situation that even in Tata, there are hardly organizations that fund women cancers, which are potentially curable, or we can give a meaningful extension of life for a young woman who's come with a stage 4 breast cancer. We can still give her a 5 to 6 years lifespan, which is free of symptoms. It still makes a lot of difference for her. Probably she can arrange things for her family before she succumbs to the disease or before she. So these kind of, there are a lot of ethical and emotional aspects also attached to it. And it's not the question of the length of life or whether it's curable or a palliative situation. I mean, people tend to keep on meditating on that fact that, "Arey, ye to stage 4 cancer hai, iska kya karna hai?" We rather give our funds to somebody who is more curable, but that's not the right thought process. And how important that person's life is, or extending that person's life by 3 years or 4 years, it depends on what role that person plays in the family. So these kind of aspects also need to be peeped into. And that can be done only by a very strong medical social worker department, because it's impossible for doctors to keep looking into all these things. It's just very, very difficult in a busy practice. So we need to have a department trained for that. And there are training courses also for that. There are training courses in Tata for MSWs. And so something like this needs to be done for every hospital.
Yeah, and for a doctor, every patient sounds important. It is not
Yeah,
that...
absolutely. Absolutely. Yes.
So I would like to thank you, ma'am, for sharing that information. I would now like to invite Dr. Murali. So do you, in your hospital, one, of course, have this social workers department? And second, coming back to, again, the oral medicine for breast cancer, can it actually remove the need for treatment methods like chemotherapy and radiation and improve the poor continuity of the treatment? So if you can reflect.
Absolutely. So first reflections on the previous question to my colleague over there. I think we cannot have one scheme or one sort of a financial option which is tailor made to everybody. We need a option which sort of fits patients who are covered under the Ayushman Bharat scheme or under any of the state government welfare schemes, wherein a larger burden of the financing is probably taken over by the financial company, and they have a direct arrangement at the governmental level. Okay, so when we talk about getting the medical social working team involved, when we talk about trying to arrange finances for the company, so patients who are taking, and if we have 100 patients, about 80 of them do end up taking treatment at the government hospitals under some kind of a government scheme. At that level, we need a different sort of a financial arrangement as compared to a corporate hospital. So working in a corporate hospital, I too work in one. So over here, we do not have a separate MSW department. Yes, each like my team, I have a MSW who helps assess and arrange finances, but there is a limit to which we can help somebody. At a corporate hospital, obviously, we will not be able to treat everybody. At the same time, there is a small caveat over here, which is that a doctor cannot, or anybody in the treating team would find it a little hard to tell a patient who's got an advanced cancer to take a loan for treatment. Okay, so this is a slightly different scenario which I'm trying to give over here. How would anyone like to hear that, yes, you have got stage 4 cancer, yes, there is advanced and a very simple effective treatment available for this, but you'll have to take a loan to do this. So coming from the treating team.
See, your mic is muted. Yeah.
So coming from the treating team, it's a little weird for the patient to hear. And that is where, companies like Arogya Finance and companies like Novartis are doing yeoman service and trying to get this message out to the wider public. So the only way any scheme is effective is if more people start utilizing it. And rather than depending on hospitals, on corporate hospitals or the treating team to push these things through, the message is better served when it is pushed on social media platforms and on other platforms this way, and that way everybody can benefit from this. So we need separate schemes for each. Most corporate hospitals will have somebody helping a patient out with the financial aspect of things, but in a true medico-social work thing. I did my training a while back in Aditya Cancer Institute. Again, it's a charity based, it's a charity driven organization wherein most of the ethos of treatment are the same as startups. So even over there, so that's a different setup altogether. So we definitely need to make horses for courses here.
And to the second part, to the second question, do you think oral medicine for breast cancer can remove the need for treatment of chemotherapy radiation?
So oral therapies are a part of the treating armamentarium for breast cancer. It can never totally eliminate. No, so any patient who's got a curative or early stage breast cancer will most certainly need the whole 3 gamut of things: IV chemotherapy along with surgery, along with radiation. There are some patients who have an extremely early stage disease in whom the chances of the disease coming back is very less. In them, we would much rather not give any treatment and just do a surgery rather than try and substitute oral with IV. So we have not yet reached a stage wherein we can substitute oral with IV. It can only supplement the outcome rather than substitute the treatment protocol.
Thank you. Thank you. I would like to once again go back to Mr. Niccolo Nitti. From a company point of view, how has the insurance coverage evolved over the years for the people, for your employees?
So it has evolved quite significantly. So first of all, as a company, we review the policy cover and provider every year. And in order to ensure that we are ahead of the market, so we have some benchmarking against other companies in order to also check what and how we are doing compared to the other companies. But when we speak about health insurance, we try always to be at the very top of the market from this perspective. We are using quite a lot of also data analytics. So, for example, through the medical claims, we can understand also a little bit the claim pattern and then invest a little bit more on the disease areas where we see that there is a certain need. And then also with our insurance coverage and offers, we are trying to cover as many people as possible. So we are not covering just associates, but also their families. So the partners and all the dependent children. We are offering also on top insurance also for parents and parents-in-law. We are, we have in the last 2-3 years, I think we have almost more than doubled also the limit of coverage. So from 2 or 3 lakhs, now we are at 7 lakhs of coverage. And then, if unfortunately the associate cannot cover all the expenses, there is also a Novartis fund which the associate can apply for in case the expenses are not bearable just with the insurance. So we are trying also to support as a company proactively with our fund.
Now, yours is a large company, and you can afford that. But what about for the small companies? Should they be also going for insurance for their employees? Usually, we don't see that in very small companies.
That's a good question. Yeah, I mean, I'm lucky that I've been working for a big company which can afford, to provide this kind of benefits to all associates. I mean, I think that more and more an associate when is joining a company, regardless if it is a multinational company or a local company, big, small company, probably these are the benefits that people are looking for, right? It happened to me, that more than once when I'm negotiating, a new contract with a new joiner, one of the questions is about the health insurance and what our health insurance is covering for. So, also the small company, if they can afford it, I do think that this is something where they should invest. Because again, in terms of talent attraction, the health insurance, I see that is becoming more and more a very important element in the decision of the people if to join or not a certain company.
Yeah, and even I feel, as a CSR also, the very first thing we talk about the 3 Ps. So we talk about people, planet, and profit. So the more you invest in your people, the more happy they're going to be, and the more they're going to be giving back to you. So yes,
Exactly.
the companies need to think about their employees and people.
Yeah. So can I
Yes,
just make a
definitely.
statement? Can
Yeah,
I
please.
just make a point? Yeah. Yeah. So it's so glad that organizations like Novartis is able to do exactly what he said on employer and the family insurance. Many companies have challenges around this. But there are also solutions available, which I think more and more companies should look at. Okay. One is often what happens is if your resources are limited, you insure your employees, but you do not insure your, let's say, aged family, parents. The need may be more for the parents. Second, if you give a coverage which is inadequate, so what is an insurance and what is my major challenge? If I am an employee of a reasonably good organization, with my earnings, I am able to take care of probably 1 lakh or 2 or 3 worth of costs. Okay, so while the company pays for it is good, but if the company were not to pay, I could have managed that cost. But what if my cost is 10 lakh rupees? What if my parents who are aged have an expenditure of 5 or 10 lakh rupees? So the care should be taken to create those kind of insurance options. So you have family floaters available. You could create co-pay options. So with the same insurance premium that a company ends up paying, you can actually create, instead of creating a 2 lakh rupee coverage, you could probably create a 10 lakh rupee coverage with a 2 lakh copay. So if I have the initial expenditure, yes, I will have to pay from my pocket, but I can sleep comfortably that, okay, if there is a major medical emergency for me or for my family members, the insurance pays for it. If you can create those kind of options, if you can cover everything like what Novartis is doing, which is very good. But if you can't, at least create options at the higher end expenditures, and the smaller expenditures should be left for the employees to bear. So that is one way you could deal with such problems. Then your children, your aged parents, all of them can be covered. The other issue, of course, Dr. Boppana mentioned about those options that are available, and especially for a Tata Memorial, more and more such people will create those kind of options for them, because that genuine treatment is happening there, and people are benefiting. Those who could not have benefited in other places, they are getting benefited, all of that. But in a country where the overall government spending on health is only 1.5% of the GDP or so, as compared to a good, developed countries where it is 5 to 10%, there will always be issues. There will always be gaps. So it can only be covered with multiple options, as Dr. Murali was mentioning. So those who can pay from their pocket should pay from their pocket. Those who have insurance fully covered, then they can take care of that. Those who do not, they have financial capabilities, then they can, people like Arogya Finance can create options for them. There are those who cannot be covered under that. Obviously, you need to create NGOs and other options for them. There are also crowdfunding platforms available, like the Keto and the Milap and various platforms who are creating their crowdfunding for treatments. So I think all of this will have to be brought together. And as Dr. Boppana rightly put it, a social worker will be able to look at what option fits that patient best, and then create those options for them. We have come across many social workers, not only, in many private hospitals have social workers. There are, like in many of those hospitals, they take a call as to whether this is a case fit to refer to Arogya Finance or similar organizations, or is it a case fit for an NGO or corporate social responsibility solutions, etc. And accordingly, then they will guide those patients to those organizations. There are many organizations where there are many patients who have been offered NGO support, but they don't want to take it because they feel that it's not the right thing to do, and maybe somebody else can benefit, and they come to us for solutions, because all that they need is a solution, a cash flow mismatch solution. Okay, they can pay over a period of time, monthly, but they don't have the money in the pocket today to pay. So they come to us even when NGO options are available, and that's a good thing, so that those NGO options can go to somebody else. So all these options have to be brought together to be able to at least solve a significant part of the problem. And similarly, when it comes to the NGOs, now the other issues come up. Okay, is he a breadwinner, chances of success? But I am a patient. I want to live as long as I want to live. And if any options can be created for them, I think we are duty bound to create. One thing, the reason why we stumbled upon this healthcare financing solution very accidentally, and one thing that we realized is, there is, while on one side, medical shocks are creating 4 to 5 crore poor people in this country every year. People who have been well off or reasonably okay, looking after their families with their earnings, something happens with the family or a breadwinner, and the whole family is back into poverty. And this is completely preventable. So it's not that these people are poor and they can't afford anything. There are, if I want to buy a mobile phone or a TV, I have payment options available. But if I have an expensive treatment to make, I don't have options available. Why? And if those options were available, I could have taken that and I could have treated and I would have been fine, or my family would have been fine. So creating such financial options are very important for those who have the ability to pay over a period of time. And one of the reasons why we started Arogya Finance is when we realized here is a large number of a segment of people who are telling us and who are demonstrating through repayments that we are a reliable set of people. We need this option, and we are very happy to pay that back. Okay, so that so that our treatment costs are taken care of. So that is the segment. So those who are above poverty but not very well off, they need these financial options. Create those EMI options, and they're very happy to pay back. Our people, even when we are giving out funds for critical care like oncology and others, the repayment track is 97% and thereabouts, which is.
In fact, I wanted to ask you: have you had cases people have not repaid?
Of course, there are people who have not been able to repay. Most of them because their financial situation have deteriorated because of something or the other. But there are also some of them who have taken advantage of the situation. We do take whatever remedial action possible where we are convinced that they are doing it on purpose. But if they have lost their ability to pay back, etc., what can you do? So we do have, but our repayment track is decent enough so that we feel confident to go out and lend to more and more such people.
Dr. Murali, have you had any cases where people have not been able to get funds or insurance they don't have, and that impacts their treatment?
Unfortunately, that is a fairly regular scenario in Tier 1 corporate hospitals. We do find workarounds for this because ultimately, as Dr. Boppana also said, we are physicians, and for us, treating our patients at any and all costs is necessary. Most of the times, we try and find some kind of a mechanism in which we are able to try to get the treatment for the patient. And if for whatever reason it's absolutely not possible, we have collegial connects across at the government facilities where we should be able to refer them and ensure the treatment, if the patient gets the right treatment.
And what about Ayushman Bharat? That covers breast cancer.
So Ayushman Bharat definitely does cover breast cancer, but then again, with Ayushman Bharat, there are certain specific issues with that, in the sense that the coverage under Ayushman Bharat is specified to a particular line of treatment, or it has got a cap. Like there is an unlimited coverage of Ayushman Bharat. So which means that under Ayushman Bharat, if somebody needs IV chemotherapy, then they have a specialized package for which the hospital is reimbursed. Now, when we talk about advanced targeted therapies like the one which Novartis has, or or the other MNCs have, they usually are not covered by Ayushman Bharat, and that is where the necessity for finance companies comes, and that's where we want them to work in tandem with the government companies. That way, the patient gets the benefit of the latest treatment.
But you've been able to voice this to the government that this all should be covered?
In fact, the government has been very receptive to ideas. So this insurance, at least the Ayushman Bharat, has not been a one rigid static kind of a thing. So from the day that it has been announced, periodically it is reviewed. Most of the stakeholders in the society do voice out their opinions to the relevant authorities, and modifications are made. So at starting, the coverage was, let's say, X amount of money. The coverage has substantially gone up in certain types of disease conditions like cancer or like heart disease. We know that where the cost of treatment is actually quite high, there the coverage increases. At the same time, when we talk about the coverage, some of the time the rarer disease were not covered under Ayushman Bharat. Now even that has started to be covered under Ayushman Bharat. So it's an evolving process. Even these medications that we are talking about, they have been fair came into the picture maybe 3-4 years ago, especially to India, and the option of separate financing to patients who need these medications, that has also been a fairly new concept. So the government is considering these issues, and then I'm sure in due course they would make modifications necessary.
Yeah, and I feel apart from the awareness about the disease, there has to be a greater awareness among the patients about the funding and the insurance aspect also. And that is where, as you said, that even in the hospitals, though the doctors don't have that much time because your concentration or focus is more on the treatment. But then we need to have certain departments which can work with these funding agencies or with the government financial institutions.
And if I may, earlier also this point was very well highlighted by one of my esteemed panelists, that the amount of under insurance which happens in India is quite significant. So although in the last 5 years we've been able to increase the coverage, the base of the people who have been insured, most of the times insurance caps are either 2 lakhs or 5 lakhs, and only now we've known that how quickly medical costs can escalate, especially during the COVID pandemic. Cost escalation was a major issue. So, along with this, hopefully in the next year or two, awareness will seep in that we need to also ensure optimum coverage. So if you ask me, in today's day and age, to cover complex diseases like cancer or organ transplant, insurance coverage has to be at a bare minimum of 10 lakhs or maybe even more than that.
If I can ask Dr. Boppana, what are the ways in which advanced breast cancer treatment can be made more effective?
Again, here it depends on what type of breast cancer that we are dealing with. By and large, whether it's hormone positive breast cancer or hormone negative breast cancer, whether it's HER2 positive, HER2 negative, because we have many new and very effective molecules like what Novartis has, CDK4/6 inhibitors, which have come up and are being used over the last few years, and they are showing some very encouraging results. So inclusion of targeted therapies is something which has really acted as a game changer in the last few years as far as breast cancer is concerned. So those patients who have recurrent disease, stage 4 disease, who have already received all the conventional chemotherapy drugs and other conventional treatments like radiation and all, targeted therapies are making a lot of difference in their lives. At least some of them. I mean, all the targeted therapies may not be as effective, but some of them are really making meaningful differences in their lives. So addition of targeted therapies is something which has really changed the game in the last few years in breast cancer, which are expensive. Which are again,
yeah.
Yes.
And even, post-recovery also, the counseling is offered to the patients?
Recovery as in like after they are done with their treatment?
After you've done with the treatment, and even there are cases, we've seen cases where it has reoccurred. So
yes.
After, when you have completely recovered, you feel you've recovered, but it might come back again. So it should not come back again. So any counseling done?
Yes, we do that. If it's an early stage patient who's been completely cured of her disease, we always tell her what are the warning signs that the cancer might have returned.
Ma'am,
So we ask her to report to us whenever there is a bone pain or there is dry cough that's not going away for more than 2-3 weeks. If there's any breathlessness, if there's any abdominal pain or anything abnormal, any lumps here and there in the neck or in the armpit that she notices. So that way we warn every patient of what could be the signs of recurrence, and we tell her to report to us immediately. And we keep the patient on regular follow-up. Every 3 monthly thorough clinical examinations are done for the first 2 years after treatment completion. And beyond that, once in every 6 months, we call the patients for up to 5 years. And if the patient crosses a time point of 5 years without having a disease recurrence, then we call the patient annually for follow-up, or we tell her to report to us whenever there is some problem. And in the other scenario where the cancer is quite advanced, it's not curable, it's in a stage 4 kind of a situation, then there is nothing like an end point. There's nothing like treatment completion in them. It just goes on and on, just like the treatment of diabetes or high blood pressure. The treatment will keep on going for as long as the patient is alive. and as long as the patient is fit enough to take some treatment. So it just goes on. It's like a continuum. Either we discontinue the therapy because nothing is working and there's nothing more left, and then we just offer palliative care to those patients, or we discontinue treatment because the general condition has deteriorated so much that the patient is no longer fit for any oncological treatment, or we discontinue treatment if the patient has had an excellent response to these therapies so much so that we decide to give a treatment break, which is a little rare scenario. It doesn't happen so commonly. Most of the time, it's the first two scenarios that I've told where we discontinue therapy in an advanced breast cancer patient.
And Mr. Peter, is it, I mean, if there is a reoccurrence and refunding or reinsurance, how easy or difficult it is?
Yeah, so yeah, insurance obviously, you know, it is whether you have the limit available, and if it happens in the same year, and if limit is not available, that's an issue. But if it is in a subsequent year and if the limit is available, then it will be available. That's not an issue. As far as financing options are concerned, also, yes, certainly those you know, additional requirements can be covered. You know, by the time we would have also known that the family's repayment track, etc., we would have already seen. So it actually makes it even easier for us to create options for them the second time around. So that's not a major issue. We can create those options.
And would you recommend health insurance to someone who has had a family history of breast cancer, or someone who's in the last stage?
Yeah, so, you know, when a patient is already having a problem, recommending insurance to them don't make enough sense. But we do counsel the family as to, you know, why it is important for the family members, especially the breadwinner, etc., to be insured. You know, that's a time when they will be more receptive to those kind of counseling, because they know that, you know, they have suffered for the lack of it. And therefore, you know, you counsel them to take proper insurance. See, unfortunately, you know, Dr. Murali, I think, mentioned that, you know, today, the Ayushman Bharat 5 lakh rupee cover has become aspirational for the middle class. Because now the poor has a 5 lakh insurance family. But many middle class families don't have so much. They think they are insured with 1 or 2 lakhs. And only when they are hit with a problem, they realize that, oh, this is not going to cover our needs in any manner. So, yeah, enough awareness on the adequacy of the insurance, I think it's very important. You know, creating those options. I'm sure the insurance companies and all that are doing their job, but I think more and more such awareness is required, so that people are aware that, you know, the fact that when I heard that 94% of people who have insurance are underinsured to the extent of 60%, I thought there's some mistake in that data. Then, you know, over some time I realized that no, there's nothing wrong in the data. It's just that that's the reality of the country. Because when you take the insurance, probably those numbers were adequate. But over a period of time, they become extremely inadequate, and you don't realize, and then you don't, you know, you don't increase those limits as you go forward. So those are very important. They need to do that. And my advice always to those who have difficulty in paying that insurance premium is that you take out floaters, you know, and you know, the small amounts you can pay out of pocket. But the larger amounts is where you really need cover. And so go out and take those kind of policies. That's always what we advise. We also have created an option called a pre-approved loan concept. So which means, you know, if you don't have insurance, or if you don't want to take an insurance for whatever reasons, you know, you can at least get a loan pre-approved. So we have an Arogya card, which is nothing but a pre-approved loan for the card holder and the family members. Up to 5 members of the family can be covered. So you get a product, you know, a card pre-approved, carry it like a cashless insurance card in your pocket, go to any hospital and get treated. and we will pay for it from the card. So, so those kind of options also we are creating for those who have inadequate insurance or don't want to have insurance for whatever reasons.
Thank you. Thank you. Dr. Murali, do you think that if the government increases its contribution or share, its spending in the healthcare sector, it can actually help in expanding the insurance coverage?
Oh, absolutely. Because see, India's overall spending on healthcare as a percentage of the GDP is still very, very less as compared to most of the advanced societies. In the US, healthcare is such a big issue that influences election outcomes. In the UK, NHS is now used as a model of treatment across the world. And NHS funding is to the tune of 12 to 14% of the GDP, and we are just we are in the single digit percentages, the low single digit percentages. So it will go a long way. See, as a country, India has got a lot of priorities, and the only thing I can say is that at least this issue of took a significant significant step when Ayushman Bharat came into play. And Ayushman Bharat, when it came into play, if you saw, it started with a 2 lakh coverage. Now that 2 lakh coverage got increased to 5 lakhs, and now with feedback from all the stakeholders in the society, that coverage might even go up. So I am sure we are on the right track, but still a lot more to do.
Still a lot needs to be done. True. Mr. Nitti, from the company's point of view, what is your take on how companies can ensure that everyone gets equal access to quality healthcare?
So that's a good question. And I think it's a matter of also collaboration and dialogue also with the insurance company, right? In order to have a broader definition of, for example, of, family, or the definition of spouse and partner. And maybe accepting also, to have LGBTI friendly policy. So I do think that, it's a collaboration with the insurance company in order to have a broader and broader definition. So, for example, what we are doing in Novartis, for example, we have agreed with the insurance company that, for example, a spouse or a partner at the end of the day is the same thing. We have worked with them in order, to accept, for example, people of different or couple of the same sex. So. And I'm saying it just not as an employer, but even more as an employee and as an individual, that we should really work hard in order to ensure that every person, irrespective of gender, of caste or creed or sexual preferences and so on, are getting the same equal treatment. And I have to say that I'm lucky enough to work in a company where I can do these kind of things, and I can really negotiate the broader definition, as I said, of a family, of partner and spouse, and again on LGBTI friendly policies.
Good to know. Good to know. Companies like yours is, assuring good quality healthcare to all people, irrespective of their gender, caste, creed.
Absolutely.
And I think more and more companies should be moving in that direction. And even more, it has to come, as it was mentioned by both our doctors and also by Mr. Peter, that even the government needs to be more speeding up and more contributing. The more concentration on healthcare has to be there when budget is presented.
Yeah, I'm happy also to see, because I attended another meeting about LGBTI with some other Indian company, and I see that more and more also the Indian companies are trying to work on this element, and are trying to really embrace more and more diversity, which is something again very much important.
Yeah, so that's good to know that our Indian companies are also rising to the occasion. They understand the need, and thank you for that. So we just have a few more minutes. I'll just take a last word from all our speakers. If I can go to Dr. Boppana first, uh, what all we can do to actually make funding or insurance uh, more for the people who are suffering, who have breast cancer, and we can save lives.
Yeah, so we need to work at different levels here. First, from the population perspective, more awareness about having a health insurance, first of all, is something because, like in my practice, almost 60% of the patients do not have, who don't come under the state government health schemes, they don't have any health insurance. So at their level, we need to bring more awareness for taking a health insurance policy in the first place. And second thing is oral drugs, which are many times not covered under insurance. That is one problem that we keep facing because it's only IV, and only IV medication that the insurance companies give. And there might be a few exceptional exceptions to this, but most of the time we see that oral medication, like most of these targeted therapies are oral tablets and they are not given. So we need to talk to the insurance companies and conduct similar meetings in order to coax them to include oral drugs also in their coverage. And the other thing is, as I said earlier, every hospital or at least a group of hospitals have to work out and create a social worker department which can track the various funding sources and help the patients out. And the fourth thing, many companies like Novartis are coming up with this patient assistance program where like through insurance companies like Arogya Finance, what they are doing is that they are giving it in an EMI kind of a scheme. Like for example, there are certain targeted therapy injections which are very costly, one injection costing 2.5 to 3 lakhs. And instead of paying the entire amount at the same time, they are they're converting it into an EMI system and with a very low interest. And that is helping some patients because the patient may not be able to pay the whole thing at a time, but eventually over a period of time, they may be able to pay it. So they're dividing it and using an EMI system. Some of the companies are coming up with this kind of a scheme. And obviously strengthening the existing government health schemes, ensuring more coverage and more spending of the government on healthcare is something which is probably like it needs to come at a much bigger level. The change needs to come at a much bigger level. But yes, I mean, like obviously many drops together only form an ocean. So it needs to start somewhere, and big companies like Novartis and other multinational companies, they need to take up this and so that more patients can benefit and benefit much more. And these targeted therapies are available even for Indian patients, and they're not something which we just read in textbooks and journals and which are only given to patients in the West. It should not be that kind of a scenario. I mean, like there are so many advances happening, but they're not reaching our patients to the extent that they need to reach because of all these restrictions that we have here in our country. So these are some of the things which can be done.
Thank you, Dr. Boppana. Dr. Murali now.
Yes, so investment in healthcare has to be pyramidal, with maximum investment being done at the screening level, at the prevention level, and at the diagnosis level. Many a times the cost of diagnosis itself is too high that the patients do not reach the level of treatment. So the more and more that we are able to spend at the education and the prevention level and at the screening level, the less we will have to spend at the treatment level. So that is one. Second, obviously, is that we need companies to partner with the pharma companies, the MNCs, to partner with insurance companies to ensure that no treatment is rejected unnecessarily out of the hand. And this is in continuation to what my colleague just said, because somebody received a targeted or a immunotherapy, insurance cannot say that immunotherapy is not covered or target therapy is not covered. So technicality should not be arrived at this stage, number one. Number two, as and when newer medications are arriving in the market and the cost of therapies go up, in tandem, the insurance cover should also go up, and that leap of faith has to be made, because a drug is only as good as it reaches the patient who deserves it. If it's not reaching the patient who deserves it, then the drug is as useless as a sugar pill. Thank you.
Yeah, Mr. Peter, your views.
Yeah, I want to again emphasize on the counseling piece. One of the data points that we have is, for every patient who ends up taking a financing option, about 4 or 5 patients end up getting the treatment. Now, why this is happening is very often patients, are reluctant to get into treatment. One, because they think, okay, at this advanced stage, why should I burden my family and things like that? So many of them don't want to get into the treatment. There are many challenges. Others feel that, okay, I can't afford it, let me go for some alternate options, etc. So they don't get into treatment. The moment the financing option or an EMI payment option is provided, they get into treatment. And once they get into treatment, they will soon realize somehow or the other that either they can pay for it or somebody in the family is willing to pay for it, because traditionally, historically, families used to find ways to pay for treatment. So somebody or the other pays for it and they get the treatment. So it may not be very good for Arogya Finance, because we are not getting those patients into our this thing. But we are very happy that for every patient we finance, maybe 5 patients end up getting the treatment. Counseling them on the availability of these options is as important as giving clinical counseling. Because what is good about clinical counseling if they are not going to get into it? So we need to find a way for them to get into treatment, and these options and these counselings help probably 5 times more than even other options available. So it's I want to overemphasize and re-emphasize the fact that counseling on the finance options is very important for treatment.
And the last word from Mr. Nitti.
So I would reinforce again the importance of awareness campaigns, and now I'm talking from a company perspective, because this is something which all the companies can do, regardless of the sector they are working on. So it's not because we are pharma, so we do awareness campaign and an FMCG company cannot do it, right? Also because, for example, coming from Europe, there are already some companies from FMCG, for example, inviting experts or also us as a pharma company and our medical advisors to speak about certain disease and making awareness into their employees. So again, I would say awareness about the disease areas, awareness about the importance of prevention, and the importance to promote and having a health insurance for their associates.
Thank you. So thank you to all our panelists. So from prevention to cure, it starts with the first creating awareness. And as was mentioned, awareness or counseling, not only about the clinical treatment, but also about the funding. Creating awareness needs to be done. The government spending, of course, in the healthcare needs to increase, and the companies need to be playing a more responsive role towards their employees, taking care of the employees. As was mentioned, that a lot needs to be done in this field. But yes, there has been an improvement which we have been seeing from the government side also, with the various private financial companies also available. But again, at the hospital level, almost all hospitals should have a social working department which can assist, which can guide the patients. So together we can in fact prevent this disease and make a difference in the lives of the people. So thank you once again to all our esteemed panelists, thanking Dr. Boppana, thanking Dr. Murali, many thanks to Mr. Peter and to Mr. Nitti. So with that, thank you to all the participants. Also hope we have been able to create awareness among the people also about breast cancer and also the funding options which are available. Stay tuned to all our series which we are going to be bringing. As I mentioned, this is a full month we are covering breast cancer from the 1st to the 31st. So more sessions which will be further guiding you and sharing information on breast cancer. Stay safe, stay healthy, and stay happy. Thank you.
Thank you. Thank you, Vimmi.
Thank you and good day.
you.
Thank you. Bye.
Thank you.